Good day, dear colleague. Today we talk about hemodynamic disorder, thrombosis and embolism. Just a moment. Okay. Normal circulatory function requires uninterrupted flow of blood from the left ventricle to the further capillary in the body, return to blood from systemic capillary network into the right ventricle, and from the right ventricle to the vastus, pulmonary capillaries, and back to the left atrium. There are three essential requirements to maintain normal blood flow and perfusion of tissues: normal anatomic features, normal physiological controls for blood flow, and normal biochemical composition of the blood. Derangement of blood flow or hemodynamic disturbance are considered under two broad headings. The first, disturbance in the volume of the circulating blood. This includes hyperemia and congestion, hemorrhage and shock. And the second, circulatory disturbance of obstructive nature, thrombosis and embolism, ischemia and infarction. Hyperemia and congestion are the terms used for localized increase in the volume of the blood dilated vessels of an organ or tissue. Hyperemia, increased volume of blood from arterial and arterial dilatation, is referred to as hyperemia or active hyperemia. Active hyperemia is augmented supply of blood to an organ. Congestion, impaired venous drainage, is called venous congestion or passive hyperemia. Passive hyperemia or congestion is engorgement of an organ with venous blood. Clinically, hyperemia is characterized by redness and rising temperature in the affected part. The affected tissue or organ is pink and red in appearance of erythema. The dilatation of arterioles and capillaries is affected either through sympathetic neurogenic mechanism or with the release of vasoactive compounds and vasodilatation. The examples of active hyperemia are seen in the following condition: inflammation, for example, congested vessels in the walls of alveolar or pneumonia. The most striking active hyperemia in the result of bacterial infection and damaging vessel wall. High-grade fever, cutaneous hyperemia in febrile state serves to dissipate heat. Goiter and menopausal flush are hormonal causes of arterial hyperemia. Blushing, flushing of the skin of face in response to emotion. Physiological response to increased functional demand, as in the heart and skeletal muscle during exercise. Skeletal muscle may increase its blood flow 20-fold during exercise. The increasing blood supply occurs by arterial dilatation and the recruitment of unperfused capillaries. Arterial venous malformation, congenital defect of arterial hyperemia, and tumor hyperemia, carcinoid flash, is a neuroendocrine tumors. Congestion. The dilatation of veins and capillaries due to impaired venous drainage result in passive hyperemia or venous congestion, commonly referred to as passive congestion. The affected tissue or organ is bluish in color due to accumulation of venous blood. Cyanosis. Acute passive congestion is clinically a consequence of acute left or right ventricular failure, and the best example are lung and liver. Congestion may be acute or chronic, and the best example lung, liver, cerebral. And accordingly, venous congestion is of two types. Local venous congestion result from obstruction to the venous outflow from an organ or part of the body, portal venous obstruction in cirrhosis of the liver, outside pressure of the vessel wall, and as a cure in tight meningitis, plaster, tumors, pregnancy, hernia, or intraluminal occlusion by thrombosis. And general or systemic venous congestion is engorgement of veins in left side or right side, heart failure, and disease of the lungs which interfere with pulmonary blood flow, like pulmonary fibrosis, emphysema. Usually the fluid accumulates upstream to the specific chamber of the heart, which is initially affected. For example, in left-sided heart failure, such as due to mechanical overload in aortic stenosis or due to weakened left ventricular wall. Acute passive hyperemia, acute left ventricular failure, the resulting pulmonary venous engorgement leads to pulmonary edema, or the accumulation of fluid transudate within the alveolar space. Chronic left ventricular failure impedes venous blood flow out of the lung to the heart and causes chronic passive hyperemia. Pulmonary congestion. As the pulmonary veins become engorged with blood, back pressure in the alveolar capillaries increases. This effect has 4 major consequences: microhemorrhaging, release in erythrocytes in alveolar space, where they are phagocytosed and degraded by alveolar macrophage. This alveolar macrophage in the Prussian blue staining is first specific blue stain for hemosiderin. The release in iron in the form of hemosiderin remains in the macrophages, which are called heart failure cells. Heart failure cells. Pulmonary edema fluid is forced from the blood into the alveolar space, a condition that interferes with gas exchanges in the lung and produces severe shortness of breath, dyspnea. Fibrosis increases in the interstitium of lung, interstitium fibrosis, and the present fibrosis and iron is viewed grossly as firm brown lung. Named brown in duration, and pulmonary hypertension. Acute passive congestion, the liver, can become severe congestion with acute right ventricle failure. A generalized increase in venous pressure, typically from chronic heart failure, result in slow blood flow, stasis, and a consequent increase in blood volume in many organs, including the liver, spleen, and kidneys. Acute congestion leads in centrilobular stasis of blood that fills the central vein and the sinusoidea around it. If the congestion develops suddenly and a large amount of blood is retained in the liver, the centrilobular hepatocyte will undergo necrosis. Congestion heart failure is secondary to coronary artery disease and hypertension, and right-sided heart failure due to pulmonary disease are common cases of passive congestion. Chronic passive hyperemia. Passive congestion of the liver is classically also termed nutmeg liver. The hepatocytes die off and are replaced by fibrous tissue. The cut-full surface of the liver in such cases has the appearance of nutmeg. The fibrosis may progress and the nutmeg liver may transform into cardiac cirrhosis. Note the dark red congestion region and represent the accumulated red-blue cells in centrilobular region. Microscopic nutmeg pattern result from passive congestion around central vein. If the passive congestion is pronounced, then there can be centrilobular necrosis. The light brown pigment seen here in the necrotic hepatocyte around central vein in lipochrome is lipochrome. What is different between active hyperemia and congestion? Resume is hyperemia which active processes the increased blood influx into the tissue result from dilatation of arterioles. Typically this occurs in inflammation, Hyperemic tissue contain increased amount of oxygenated blood, and therefore such tissue appear bright red and hyperemic tissue and are warm. In contrast, congestion is a passive hyperemia, result from stagnation of blood in the capillaries caused by impeded outflow of blood on the venous end. Congestion tissue contain increased amounts of deoxygenation venous blood and therefore appear dark-ski red or bluish. The congested tissue are clammy and cold. Obstruction of veins with thrombi or backward pressure caused by heart failure is typically accompanied by congestion. Hemorrhage. Hemorrhage, extravasation of red cells due to vessel rupture, is called hemorrhage. Hemorrhage or bleeding is escape of blood from blood vessels or the heart. Hemorrhages can be classified according to the site of origin. Cardiac, they are usually caused by penetrating wounds or a rupture of ventricles as a result of myocardial infarction. Arterial, these are usually caused by trauma or rupture of an aneurysm. Capillary, these are usually caused by trauma or surgery, but they may also occur in a variety of diseases characterized by weakness of vessel walls, as Ehlers-Danlos syndrome and vitamin C deficiency or platelet disorder, idiopathic thrombocytopenic purpura. And venous hemorrhage, these are commonly caused by trauma or surgery. A few definitions are in order. Hematoma, hemorrhage into soft tissue. Such collection of blood can be merely painful, as in a muscle bruise, or fatal if located in the brain. Accumulation of blood in body cavity. Such hemorrhage are named by combining the prefixes hem or hemata from Greek hema, blood, plus anatomic site involved. Hemopericardium is hemorrhage into the pericardial space. Hemopericardial space. Hemothorax, hemorrhage into the pleural cavity. Hemoperitoneum, bleeding or hemorrhage into the peritoneal cavity. And hemarthrosis, bleeding into a joint space. Classification of hemorrhage into the skin and mucus is arbitrary and has solved only by tradition. Note that petechia often become confluent and become purpura or ecchymosis. What are differences between petechia, purpura, and ecchymosis? All three terms refer to hemorrhage in the skin and mucus. Pinpoint hemorrhage. Smaller than 1 millimeter are called petechia. Usually the skin or conjunctiva, these lesions represent the rupture of capillaries or arterioles and occur in conjunction with coagulopathy or vasculitis or bacterial endocarditis. Thus, measuring 1 millimeter to 1 centimeter in diameter, all called purpura. Diffuse superficial hemorrhage in the skin up to 1 centimeter is ecchymosis. Large superficial hemorrhage is the small, measuring 1 millimeter of diffuse superficial hemorrhaging is upper, it's named ecchymosis. Large superficial hemorrhage in the skin is purple at first, then tone green, then yellow. A good example an ecchymosis is a big black eye. Hemorrhage is appearance in blood in urine, name it hematuria. It may be classified as microscopic or macroscopic if visible to the naked eye. Hematuria may be a sign of kidney or urinary tract diseases. Hematemesis is vomiting of blood. Typically, it is a sign of esophageal and gastric hemorrhage. Common causes of hematemesis are ruptured esophageal varices and peptic ulcer of the stomach and duodenum. Hematochezia is bleeding through the rectum. It is typically caused by diseases of the large intestine. Hemoptysis is bleeding from the lung. Literally, it means spitting of blood. Metrorrhagia occurs at any time and is not related to menstrual bleeding. What is color of hematoma and evolution? This sequence of events reflects progressive oxidation of bilirubin released from the hemoglobin of degraded erythrocytes before resolving. The first, it is red, and then as bluish red is the oxygenation. It becomes darkly and bluish red. As the red blue cells fall apart, biliverdin form, and the hematoma will appear greenish. Bilirubin formed from biliverdin will give it a yellow, who after that the remnants of the red blue cells may be resorbed and the tissue resume its normal color, or iron porcine hem pigment is taken by macrophages and degraded in hemosiderin, which gives the tissue a brownish color. Hemostasis, stopping of hemorrhage, is the physiologic process designed to stop the bleeding from ruptured blood vessels. Thrombosis is a pathologic form of coagulation of circulating blood inside intact vascular spaces. The main components of the hemostatic processes, both hemostasis and thrombosis, depend on the interaction of numerous components which can be grouped as related to the vascular or vessel form, platelets, coagulation protein of the plasma, name it coagulation cascade. Vascular wall consists endothelium or endothelium. How does endothelium of blood vessel act on the coagulation of blood? Endothelial cells have both procoagulant and anticoagulant properties, and according to the needs of the body, they may either promote blood clotting or inhibit it. Endothelial cells have a Dr. Jekyll and Mr. Hyde personality. Strange Cases of Dr. Jekyll and Mr. Hyde is a Gothic novel by author Robert Stevens. It's very seems our lection of endothelium, because two person is one in same person. Always think of endothelial cell as being Dr. Jekyll and Mr. Hyde. Normally, Dr. Jekyll, antiplatelet properties, has anticoagulant properties and fibrinolytic properties. If we talk about Mr. Hyde, we talk about endothelium injury, is a procoagulant properties. Anticoagulant function of endothelial cells include antiplatelet properties, inhibition of platelet aggregation. Endothelial cells secrete prostacyclin and nitric oxygen, which dilated blood vessels, thus increasing the blood flow and reducing the chance of adhesion of platelets to the vessel wall. Anticoagulant properties, inhibitor of platelet antithrombin activity. This is mostly accompanying membrane heparin-like molecules and by thrombomodulin, which captures thrombin and submit it for degradation by the anticoagulant protein C. And fibrinolytic property or fibrinolysis. Endothelium secretes plasminogen activator, which generates plasmin from plasminogen. Plasmin lyses fibrin and prevents the growth of the clot. How does endothelium promote blood clotting? Mr. Hyde. Endothelial cells promote blood clotting through several mechanisms that are counterbalanced by the anti-clotting forces. Prothrombotic property, procoagulant mechanism, makes one Willebrand factor, which the binding of platelets, coagulation factor H, make tissue factor, thromboplastin factor 3. This promotes the extrinsic pathway of the coagulation cascade and make plasminogen activator inhibitors PAI. Endothelium activated by infection against hemodynamics, plasma, anything which disrupts it, including physical trauma. Second, platelets. Platelets, also called thrombocytes, are enucleate discoid structure derived from marrow megakaryocyte. It is megakaryocyte, and these very small platelets. Platelets include alpha granules, fibrinogen, fibrinectin, and factor granules and contain a number of ready-made biologic activity substance, factor 5, factor 8, platelet factor 4, and transfer factor growth beta. Delta granules, dense bodies contain mediators of inflammation: histamine, serotonin, calcium, and ADP, ATP. Cytoskeleton, this is composite of tubulin, actin, and myosin filament that allow the rapid extrusion of granules from the cytoplasm. Microfilaments are and microtubules also mediate the change of the shape of platelets and account for the clot retraction. And adhesion molecules and receptors. Thus, glycoprotein are expressed on the cell membrane of activated platelets, allowing them to adhere to fibrin again and one Willebrand factor and also each other. And phospholipids, their cell component, include platelet factor 3, actives and calcium stored in dense granules as cofactors in the coagulation cascade, and platelet with endothelium form tissue factor. Okay, let's take a 5 minutes break. Okay, continue. Platelet phases included adhesion, secretion, and aggregation. Platelet adhesion is an essential function in response to vascular injury and is generally viewed as the first step during single platelet binding through specific membrane receptor to cellular and extracellular matrix constituents of the vessel wall and tissue, and regulated by Willebrand factor, which brings platelet surface receptor to extracellular matrix collagen. This response initiated thrombus formation that arrests hemorrhage and permits wound healing. Second step, platelet secretion, both granules alpha and gamma, and binding of agonist to platelet surface receptor and intracellular protein phosphorylation. This main contain. And third step, platelet aggregation, contain adipoadenosine diphosphate, thromboxane, thrombin from coagulation cascade, and fibrin, future trenches, and hearts and contract the platelet plug. Primary hemostasis is a normal hemostatic mechanism and the first stop hemostasis included three components: vascular component, endothelium injury, and vascular component. This involves the reflex spasm of the injured vessel, which minimizes blood losses. Platelet component, following vessel constriction, platelet adhere to the vessel wall and also aggregation to form a platelet plug which seal off the vascular bridge and arrest hemorrhage, primary hemostasis. This is following by activated of coagulation cascade and fibrin deposit and activation and aggregation. Coagulation cascade is a secondary hemostasis. Containing pathway, three pathway. Extrinsic begins when there is injury to endothelium. Intrinsic begins when factor 12 is exposed to collagen, kallikrein, and high molecular weight kinin. And common begins as factor 10, which inactivity to factor 10A. This cascade is memory, if you have remember, if you have used number factor in age up to 11 years. Same situation. Intrinsic pathway, the collagen. Extrinsic pathway of coagulation begin when factor 7 is converted to factor 7A by tissue thromboplastin, tissue factor. 9. Factor 10 then converted prothrombin as a common factor. Intrinsic pathway of coagulation involves deactivated all clotting factor except factor 7 and 13. Common factor. Factor 12, hegemon factor, is activated by exposed subendothelial collagen and high molecular weight kininogen. It may also be initiated factor 7 from the extensive pathway, activated factor 9 to 9A. Factor 9 leads to the conversion factor 10 and factor 10A, catalyzed by factor 8, an intrinsic pathway activated by the platelet phospholipid complex. Coagulation test is very important and include this parameter: partial thromboplastin time, prothrombin time, and international normalized ratio, extrinsic pathway criteria, bleeding time, platelets and platelet count, fibrinogen, and factor SA. Thrombosis. Thrombosis refers to the formation of a thrombus, defined as an aggregate of coagulated blood containing platelets, fibrin, and interacted cellular elements within a vascular lumen. It's a prostatic thrombosis. In 1845, Rudolf Virchow, the famous German pathologist, suggested that three factors promote thrombosis, collectively known as Virchow triads. Virchow triads include endothelial injury, changes in blood consistence, formed hypercoagulable state, and abnormal flow, changes in the pattern of blood flow, stasis or turbulence. Endothelial injury, there are two main reasons. Damaged endothelial cells produce or release procoagulant substance, thromboplastin, von Willebrand factor, PF, and inhibitor of plasminogen activator, whereas the production of anticoagulant substance, thrombomodulin, antithrombin 3, nitric oxide, and plasminogen activator, and is reduced. Loss of endothelial cells exposes the underlying basement membrane or collagen in the wall of the blood vessels, allowing the binding of platelets to the structures. Binding of platelets to the solvents, mediated by von Willebrand factor, leads to formation of platelet aggregates and initiate the formation of thrombin. What are the common and important causes of endothelial cell injury that initiate thrombosis? The first, hemodynamic injury as a result of high blood pressure, atherosclerosis, infection or thrombophlebitis, autoimmune diseases, polyarthritis nodosa, metabolic disorder, hyperlipidemia and homocystinemia, and trauma or surgery. Abnormal flow, which changes in the blood flow predispose to thrombosis. There are two principal changes in blood flow: non-laminar flow that predisposes to thrombosis. First, turbulence flow, typically encountered in abnormally dilated heart chambers that are not contracting regularly, or arterial aneurysms. And stasis, typically found in dilated veins. How do hemodynamic changes promote thrombosis? Altered blood flow may cause endothelial cell injury or increase the coagulability of the blood. Several mechanisms may play a role, such as the following. Turbulent flow may mechanically damage the endothelial cells. Turbulent flow or stasis may activate endothelial cells and stimulate them to secrete procoagulant at the expense of anticoagulant substances. Stasis or turbulent flow may bring platelets and leukocytes in contact with the endothelial cells and facilitate their attachment. Stasis may reduce the inflow of fresh blood that contains natural anticoagulants. Stasis may retard the removal of small platelet aggregates that would have floated away in normal circulation, thus allowing the buildup of the thrombus. What are causes of hemodynamic changes that promote thrombosis? Venous thrombi are most often a complication of varicose veins. Arterial thrombi develop in aortic aneurysm and over-ulcerated atherosclerotic plaques. And cardiac thrombi develop in irregularly contraction hearts, arterial fibrillation, of the damaged endocardium, mural thrombi of a myocardial infarct, and in an infected cardiac valve, bacterial endocarditis. And hypercoagulability, increased concentration of coagulation proteins or reduced concentration of natural anticoagulant leads to hypercoagulability of blood. Thus, hypercoagulable states fall into two large groups: hereditary hypercoagulable states and acquired hypercoagulable states. Hereditary hypercoagulable states include these genetic diseases, also known as thrombophilias. Factor V and prothrombin defects are common. Mutation in prothrombin gene, mutation in methylene tetrahydrofolate gene, and rarely antithrombin 3 deficiency and protein C deficiency and protein S deficiency, and very rare fibrinolysis defects. Acquired hypercoagulable states include many conditions: prolonged bed rest or immobilization, myocardial infarction, atrial fibrillation, tissue damage, surgery, fracture, burns, cancer, Trousseau syndrome, migration thrombophlebitis, prostatic cardiac valves, disseminated intravascular coagulation, heparin-induced thrombocytopenia, antiphospholipid antibody syndrome, and lupus anticoagulant syndrome, and lower risk for thrombosis, cardiomyopathy, nephrotic syndrome, hyperestrogenic states, pregnancy for example, oral contraceptive use, sickle cell anemia, smoking, and obesity. Clinical condition complained by thrombus. A mnemonic to remember common causes of thrombosis is thrombi. Tissue damage, trauma, fracture, burn, surgery. Hereditary conditions, factor V bleeding, deficiency of antithrombin and protein C or S. Rest, prolonged bed rest after surgery or in old age. Obstetrics, normal pregnancy, eclampsia and abruptio placenta. Malignancy, blood flow disturbance, varicose vein, myocardial infarct, aneurysm and apoplexy. And immune mechanism, antiphospholipid antibody and polyarteritis nodosa, the thrombi. Morphology of thrombi. Large thrombi formed in vein, artery and heart of living person. Adherens vessel, heart, mural thrombi, arteria, and common vein thrombi, prostatic vein. Mural thrombi literally formed on the wall are thrombi attached to the endothelial surface of aorta, large veins, or the endocardium of the heart chambers. Similar thrombi found of cardiac valves are called vulvar thrombi. Vulvar thrombi are also called vegetation. And thrombi are there are obstructive and non-obstructive. Obstructive, and non-obstructive. Arterial thrombosis, different venous thrombosis, is a clinical setting. There's arterial thrombosis associated with atheroma, venous thrombosis, clinical setting, emboli person. Pathogenesis, arterial thrombosis, turbulent flow, damaged endothelium and platelet-rich. Venous thrombosis pathogenesis is stasis, hypercoagulable blood, clotting factor rich. And symptom, arterial thrombosis is sudden onset, venous thrombosis is slow onset. And complication, arterial thrombosis is infarction, and venous thrombosis complication is pulmonary embolism. Typically macroscopic and microscopic features is lines of sun. Thrombi form deposit platelets and fibrin, which form a white layer. Red blue cells deposit on this layer, forming a red layer on which a new layer of fibrin and platelets is deposited. Thus, alternating white and red lines are called lines of sun. Attachment thrombi are attachment to the surface of the vessel or heart chamber and which they were formed. Friability. Thrombi are held together with fibrin that does not permit all layer uniformly but leaves cleavage line between the white and red layers. Most thrombi will crumble along cleavage line when bent to or compression with the finger. The friability of thrombi accounts for the fact that they may detach and embolize. And molding, thrombi formed inside veins typically retain the shape of the vessel in which they were formed and appear like casts of these veins and their tributaries. Veins filled with thrombi appear expanded and may be palpated during physician examination. At autopsy, such veins appear completely filled and widened. Differentiation comparison of thrombus with a blood clot. Postmortem clot form from the blood that does not circulate. Owing the force of gravity, the red blood cells sediment and separate from plasma. Postmortem clot contain lodged red portion, it's the same currant jelly, and yellow portion is the same chicken fat. This table includes comparison of thrombus with blood count. Thrombus location intravascular, blood clot extravascular. Composition thrombus platelets and fibrin and red blood cells and have a line sign but blood clot absent line sign and in leg platelets, composite fibrin and red blood cells. And shape, the thrombus has shape, blood clot leg shape. Outcome of thrombosis, resolution, fibrinolysis mediated by plasmin accounts for the dissolution of most thrombi. Because the endothelial cell lining the veins produce more plasminogen activator, venous thrombi are leasing more readily than cardiac and arterial thrombi. Second, propagation. Thrombi that do not resolve by fibrinolysis tend to grow because of the deposition and additional platelets, fibrin, and red blood cells. Such growth is typically accompanied by the formation of downstream tail. Embolization. Thrombi may detach from the vessel wall and give rise to emboli carried downstream by the blood. Large thrombi may form fragments which also may embolize. Organization in growth of granulation tissue from vessel wall in this slide where is organization and recanalization. Recanalization, the blood vessel in the granulation tissue organizing, the thrombus may fuse into large channels that bridge the thrombus, allowing the resumption of blood flow. Possible complications of thrombosis include infraction. Occlusive thrombi may completely interrupt the blood flow through an artery, causing ischemic necrosis of the tissue supplied by that vessel. This is a typical complication of arterial thrombosis, coronary arterial thrombosis. edema and obstruction of venous outflow. This is typically seen in venous thrombosis. Emboli, thromboemboli are a common complication of thrombosis, regardless of whether the thrombi are venous, arterial, or cardiac. Infection, thrombi are fertile soil for bacteria and are easily infected. Inflammation of the vessel wall. Organization of infected venous thrombi elicits an inflammation in the vessel wall. The thrombophlebitis is associated with redness, swelling, and pain of tissues around a cord-like thrombotic vein. Embolism. Emboli are particulate fluid or gaseous material carried by the bloodstream from the site of their origin or entry into the circulation to the other parts of the body. Emboli are classified based on site of origin: cardiac emboli, arterial emboli, venous emboli, lymphatic emboli, presence or absence of secondary infection, sterile bland emboli or septic emboli, flow, paradoxal emboli, crossed emboli, emboli crossing over from venous circulation to arterial circulation or vice versa. Deep leg vein emboli cross to pulmonary circulation and then to systemic arterial circulation. And retrograde emboli travel against the direction of blood flow, a retrograde spread of prostatic carcinoma to spine via intraspinal veins. Increased pressure in the body cavities during coughing or straining carries emboli from large thoracic ducts and abdominal veins. Emboli, physical state of emboli classified: thromboemboli, this lung thromboemboli, pulmonary; air gas emboli, gas and amniotic fluid emboli, amniotic; tumor emboli, the tumor cells emboli; fat emboli, and bone marrow and cholesterol emboli. What are the most common and clinically most important emboli? Thromboemboli represent the most common and the most important emboli. Venous, these originate in the vein and are carried by venous blood into the lung, pulmonary emboli. And arterial thromboemboli, these emboli originate in the heart or aorta and large arteries and are carried by arterial blood into various organs such as the brain, kidney, and spleen. Pulmonary embolism, usually silent, have a chest pain, low partial kiss, sudden occlusion of over 60% of pulmonary vasculature, presents a high risk for sudden death, in acute right heart failure, and sound of embolism often, usually is fatal. Amniotic fluid embolism is causes of maternal morbidity during labor and immediate postpartum period. Fortunately, it is very rare, but if occurs, it's lethal in 18% of cases. Amniotic fluid contains lanugal hairs, vernix, and even meconium, which may occlude the pulmonary arteria branching and causes sudden death. Clinical findings: sudden respiratory distress, deep cyanosis, hypotensive shock, seizure, convulsion, coma, and death. Pathogenesis caused by infusion of amniotic fluid with all its content, fetal cells and debris in maternal circulation due to torn in placental membrane, to rupture of uterine vessel. Microscopic theater, pulmonary microcirculation show fetal skin, squamous cell, lanuga hair, and fat from vernix caseosa, mucin from fetal respiratory tract or gastrointestinal tract. There is pulmonary edema and diffuse alveolar damage and hemorrhage. Cases of this: mechanical blockage of pulmonary circulation, this anaphylactic reaction to amniotic fluid, hemorrhage. If the patient survives the initial phase, she may be bleeding extensively due to disseminating extravascular coagulation or disease. Fat bone marrow embolism is defined as obstruction of arterioles and capillaries by fat globule, with or without marrow element. Entry of bone marrow particles into the circulation may occur upon fracture of bones that contain hemopoietic bone marrow. Typically, it occurs during cardiopulmonary resuscitation of people who have had a cardiac arrest. Causes: trauma to lung bone or soft tissue, fracture with embolization of fatty marrow, extensive burns, pancreatitis, diabetes mellitus, vigorous cardiopulmonary resuscitation. Clinically features: clinically manifestation appear within 1 to 3 days of trauma and include tachypnea, dyspnea, and tachycardia, neurological effects, and duothrombocytopenia resulting from platelet consumption, and anemia. Pathogenesis: mechanical obstruction. Fat globules occlude pulmonary or systemic circulation, brain, kidneys, and other organs, to cause platelet and red blood cells aggregation, leading to hypoxia of the tissue and organ. Air embolism: air bubble in the circulation can obstruct vascular and causes ischemic injury. Causes: air can be sucked into the arterial and venous circulation in the following condition. Operative procedures: surgery in the head and neck and cardiothoracic regions or obstetric manipulations. Trauma, particularly penetrating chest wall injury, decompression sickness, intravenous infusions, angiography, arteriography. Arterial air embolism can also be associated with a paradoxical embolus that can travel to the arterial circulation from the venous side across a patient's foramen oval or arteriovenous shunts. Caisson disease is a specialized form of air embolism which occurs when a person decompresses suddenly across areas with major pressure difference. Pathogenesis, decompression sickness, or caisson diseases occur in individuals exposed to sudden changes in atmospheric pressure. When air is breathing at high pressure, large amounts of gas, particularly nitrogen, dissolve in blood and tissue. If they leave rapidly essence from water, the nitrogen bubbles out of the blood to form gas emboli. These bubbles lodge in the blood vessel of muscles and joint, causing veins and edema and hemorrhage in lung, causing respiratory distress or choking, and chronic decompression. Systemic emboli and paradoxal emboli due to right or left shunts. Paradoxalic emboli and for this just a moment, paradoxal emboli is an uncommon causes for acute arterial occlusion when a thrombus crosses an intracardiac defect, patent foramen arterial septal defect, ventricular septal defect, pulmonary arteriovenous malformation, intersystem circulation. This site can include the brain, heart, gastrointestinal tract. The emboli is usually a blood clot but may be affect particularly air, amnion, fluid, and tumor. Embolization is proportional to the degree of flow, cardiac output, that area and organ gets. Thank you for attention.